Please join me now in welcoming Dr. Don Rucker, the National Coordinator for Health Information Technology at the Office of the National Coordinator for Health IT. As National Coordinator, Dr. Rucker is a leader in health IT efforts and works to support the adoption of health information technology and to support the nationwide health information exchange. Prior to this role, Dr. Rucker was Clinical Professor of Emergency Medicine and Biomedical Informatics at The Ohio State University, and also served as Chief Medical Officer with Premise Health. Ohio State University is a member institution of NCCN as well. Dr. Rucker has an extensive career in informatics and co-developed the world's first Microsoft Windows-based electronic health record. This last March 9th, the Office of the National Coordinator released the final Rule 21st Century Cures Act, Interoperability, Information Blocking, and the ONC Health IT Certification Program. The final rule implements provisions of the 21st Century Cures Act related to health information technology, patient access to data, and information blocking. We are looking forward to learning more about this important rule from Dr. Rucker. Dr. Rucker, we're honored to have you join us today. Welcome.
Thank you, Bob. Much appreciated. Thank you for the invitation. As you point out, when I was at Ohio State, actually the emergency department is on the ground floor of the James Cancer Pavilion. We have a special oncology cancer track there. So I was intimately involved in all of that in very, very close proximity. So today's session is really about the Cures Act. And while most of the focus has been on the FDA, you heard a wonderful presentation from Amy, the 21st Century Cures Act in Title IV also had a big section on information technology. And so that's what we'd like to talk about a bit today. And in that, when you read that, I think Congress clearly had a vision that they wanted patients empowered with this modern technology. They wanted, this 2016, when the Cures Act was passed into law, it was really a vision of, we had smartphones, how do we make this technology work for patients? And what, in fact, were the barriers to making technology work for patients? So the IT part of the Cures Act, I think echoes the themes we've heard today, which is really addressing barriers in getting information to patients and, frankly, putting patients in control of their lives and their healthcare. We have control of our lives pretty much in every other sector of the economy. We have smartphone apps for everything, but in healthcare, we really haven't had that. So again, the law signed December 2016 by President Obama. I can assure you President Trump and the administration, Secretary Azar, Administrator Verma, ONC, we've been working very, very hard to make this a reality. So what did Congress put in there that they wanted to, let's say, diagnose and fix in healthcare IT? So I think there are a couple different things. One is Congress heard loud and clear that often this information is just not shared. We, in our payment system, have created a lot of incentives to vertical integration and not sharing of patient data. So Congress said, that's finished. You have to share data to help patients. The second thing that Congress heard loud and clear was we need modern computer application programming interfaces, right? The doors, if you will, to connect software. It's all pretty much under the radar, but smartphone apps literally have hundreds and hundreds and hundreds of thousands of interfaces that they're using, right? So if you have a map application in a smartphone, those are all APIs that can be taken for this great public good. So Congress said you should use application programming interfaces without special effort. And then finally, they wanted the health information exchanges talking with each other. So as we just pointed out, we put out a rule to get those things happening. And let me talk about each of those things and then for the oncology community. So the first part on information blocking, really that what Congress asked for there are what are the allowable exceptions? So when can you withhold the information or when can you sort of guide the way it's given? Some of these we know in our common sense, the security privacy that we spend a lot of time on as we think about our IT infrastructure. There are also a number of things there on allowable prices for those services. That's a delicate balance between having prices so that the information is shared, but not having the prices so high that it is blocked per se. We want to encourage the entrepreneurial community. So a lot of balancing things there. That's the information blocking. For all of these things, we have on our healthit.gov website, ONC's website, we have lots of information. We've done webinars on each of these topics. So for folks who are interested more, their webinars, their PowerPoint slides to give you overviews. The next area I want to talk about, I think, is really the most fundamental. And Congress put in a provision that application programming interfaces should be without special effort. And this is something Dr. Walters mentioned it, Amy mentioned it. So what exactly is without special effort? Well, I think we intuitively know we need tighter, better standards and more widely adopted standards here, right? So you don't want each vendor going off and doing their bespoke API that then ties you in to using that vendor and precludes potentially other participants in it. You'd like standards-based things. Now, IT standards in healthcare have been a bit of a problematic mess if you sort of look from a computer science point over the years. But we're in a position now to really use the standards advancement that has come throughout the software industry. And at the risk of getting in jargon, but I know it's an oncology audience, so you guys are used to very long, complex topics as the norm. Those include APIs that are what are called RESTful, which is a way of designing an application program interfaces with very elegant data payloads, very simple data payloads, something called JSON, JSON, JavaScript Object Notation. In healthcare, we've used a buzzword you may have heard of called FHIR, not fire as in F-I-R-E, but FHIR as in F-H-I-R. So Fast Healthcare Interoperability Resources. And that gives us, I think, a technology that lots and lots of developers, both within and more importantly, outside of healthcare, can now bring their skill sets, open source code, into development of new tools. So those are very exciting. They're in the rule. They have 2 and 3 year timelines in our regulatory framework to give people the chance to build these things out. What we're settling on, sorting on for the first set of data is something we're calling the US Core Data for Interoperability. And so that is things you might expect. So med lists, problem lists. What's been added there from the prior core data set are clinical notes and then some information on provenance and better demographics. So I know this is a ways to go, that starting point from what oncologists need, for example, to deal with a referral. I'm well aware of that, but we want to go from a starting point that everybody can participate in from a rule-making activity. We've done some work. I know ASCO and MITRE and folks are very involved in expanding those standards out, the FHIR standards. We have, I think, there's a standards advancement process in the rulemaking. It's not in there initially because of bandwidth issues, but I think in the not too distant future, probably one of the next big steps in the core data for interoperability will be images as opposed to just diagnostic reports. So there is a gradual process to get to the set of structured data that folks have been asking about on that. We're advancing that as well from ONC's Precision Medicine Initiative, working with NIH and the Sync for Science and the Sync for Gene projects to allow patients to share information as part of the research enterprise. So there's some very good progress going on there. There are a couple things that I think go beyond that, and this has been touched on by the prior speakers as well. So I've been involved in the getting data in EHRs literally since the very late 80s. And getting data is the best way to understand it is physics and entropy. If you remember back to pre-med physics, right? If you want to tame entropy in a system, you have to put energy in. What is energy in data? It's the blood, sweat, tears, and time of clinicians to sort that data. So I think we need to really think, what is the balance of provider burden, efficiency, data quality? That is a very, very delicate balance between what is called structured data, so highly curated data, and what is often referred to as free text data. And that's really a continuum. It's not all, or it's not one or the other. The one big thing that I would like to point out to folks that is sitting in our interoperability role, it's probably not, people haven't really glommed onto it yet, I think, is that the FHIR version 4 standards actually now has standards for what's called bulk data or population data, so that you can do queries over an entire population. Now, all of this is within the confines of HIPAA. So the prior information, the individual patient access under the individual's right of access, uses OAuth 2 and protocols for privacy and security. But the bulk data, the population data, is under the more classic HIPAA treatment payment operations. And that will allow, for the first time, I think, some practical ways of getting data out of the vast set of electronic health records. Today, most big data projects, when you dig down into them, are on individual sites, because we don't really have great ways of getting at the totality of data. Each of those are custom queries that need to be rebuilt from scratch. With the population level, this bulk FHIR interface, I think we're finally going to have the data we need. That is going to revolutionize, I think, over time, not just many aspects of oncology, but frankly, the broader healthcare. In a bulk data world, you could easily imagine with almost any machine learning technology that you can separate out quality measures without playing the entire expensive quality measure game that we've had to do because we haven't had a choice in the last 20 years. So that's going to, I think, change the approaches there. One area for folks to realize in that is, there were questions about AI and machine learning. The natural language processing, or parsing as it was originally called, the NLP techniques are now actually fairly robust. So for researchers who think they may have things in chart documentation, there are a number of tools now, and those skills are becoming pretty widely available. So, if you have an interest there, I would definitely look into it. The third area, besides the information blocking and the application programming interfaces that the Cures Act dealt with, is sharing data and information networks, so health information exchanges. Cures has something called the Trusted Exchange Framework Common Agreement, which we've shortened, as you might expect, to TEFCA. That is coming out. There's a nonprofit coordinating entity that is putting out these things for networks to share. That is very exciting. We've seen with the COVID pandemic now that the health information exchanges actually have some very, very rich data opportunities. So much of the COVID data that we have today is really fairly one-way reporting. So report to this public health agency or that public health agency. and in the case of the federal agencies, is typically de-identified. But it's very hard with that to do really longitudinal analysis, as Amy mentioned, right? So if you want to ask longitudinal questions like, what is the time between when somebody tests positive and they end up in an ICU? Or what is the time between when somebody tests positive and somebody tests negative? Or what's the time between testing positive and serology changing? Or even, are these duplicate tests? For those things, you really want a rich network over all providers with lots of information that can then answer additional questions that don't have to have forced data recapture. For example, race and ethnicity data. The health information exchanges can provide that, even if the lab vendor, for example, didn't have it. So I think we're seeing, even today, the first glimpses into that sort of information-rich world over the entire body of patient care providers. This will clearly be of great help to oncology, because a lot of this is real-time information, which is obviously central to fast-moving severe illness. And it is coming as a backdrop to patient empowerment. So we are building with modern technology the kind of consumer empowerment we've had in the rest of our lives. You know, we'd never think of going back to the old ways of banking, travel planning, checking the weather, checking sports, you know, pick your favorite pleasure or activity. We haven't had that seamless interchange of information and opportunity in healthcare. We've had this very third-party view of the world. Our vision, the administration's vision, is getting patients back in charge, both from an information point of view and frankly from an economic consumer point of view, with transparency to the entirety of the care process and the care payment process. So we're pretty excited. I think it's going to have a lot of impact on opportunities for NCCN members. So I think, Cliff, if we had time for some questions or comments.
Sure, Don, thanks very much. We do have time for questions, and we're going to we can go all the way to the bottom of the hour as appropriate here, so we've got plenty of time for that. Don, just to kick it off here, and I know you can't go back over all the acronyms and other abbreviations, but sure. I know one, FHIR, the FHIR, I mean, that is having a pivotal role, but can you tell us basically, or remind us, FHIR is going to do what for sure. Ultimately for data management and patient care? How does that filter through the system?
Right. Let me be a nerd here for a second and just give a little bit of philosophy on how things, quote unquote, interoperate. I'm still not sure if that's actually a word, but it's widely used in my space. So we'll assume for a moment it's a word. If you look at what made networks brittle, so I started, as was mentioned, the first EHR that I was involved in building, our big networking was trying to get the serial printer port to work. You know, and networking was just a dream. Someday we're going to be able to hook this up to something else. So historical perspective, if you look at some of the things that have come in the early 2000s, folks may have heard of SOAP and WSDL. Again, those are all buzzwords, but and the XML, you've probably seen some text. Those are the angle brackets. So you have like an outline with angle brackets everywhere. And what do all those angle brackets mean? The way to think about that more fundamentally is most of those things had a intermixing of the data with what was to be done with the data in a very complicated kind of recipe, frankly, right? What in 2000, 2001 came out is the concept of RESTful. RESTful is representational state transfer. So you've used this. If you've ever looked at your browser and you see gets and puts in the browser address line, so AKA pretty much every web page you've ever accessed, What makes those things possible is they're not, for the most part, and again, this is a very, very broad generality, but they're not having a huge complicated back and forth on what the data is. They're saying, get me a pile of data, and then the sorting of what to do with the data is a bit separate. That concept, which is called RESTful, that separation of concerns, turns out to be remarkably powerful in doing things. The beauty of that then, so that's one thing. The FIRE, Cliff, that you ask about comes from a realization, well, we've made the protocol simple, let's make the data simple. And the data representation that's being simplified here is something called JavaScript object notation, which sounds for all the world like something hideously complicated. Oh God, it gives you sort of a computer headache. I never liked that class kind of thing. However, what that is a very simple plain text representation with, just think of it as an outline basically of data. It's very easy. That of course has nothing, that while it's very easy and elegant, and you can look at these structures and understand them, just you open them up in Microsoft Word. It's that straightforward and simple and obvious. Problem is, it didn't bind in healthcare terminology. And as we know, terminology is absolutely critical. So by binding in the healthcare terminology, that's what FIRE does. So FIRE is Fast Healthcare Interoperability Resources. Think of it as binding healthcare terms and structures, what's a lab kind of thing, into a, and those terms into a very simple data structure that you can then move and concentrate on security things. That's the power of FIRE. It has had very rapid uptake, a lot of excitement, a lot of people building around it. I know it hasn't fully come to everybody, but the development acceleration here is stunning. So I think we're all going to see this pretty quickly.
So ultimately, though, what FIRE does is it sort of embraces or links or incorporates maybe medical kind of health lingo into something that is interoperable and more efficient.
Precisely. That's exactly what it does.
And then for somebody, an oncologist in an office, shall we say, benefits from that how?
So the clinicians and patient benefit because it just makes the formulation, the building of software, and the transmission of this data at each step of the way simpler, right? It allows APIs, which we're frankly requiring, so that of course is a requirement, but it allows these APIs to be built by more and more people. I think you're going to see, there right now are roughly 250,000 healthcare apps. Almost every one of those apps has no relationship to any clinical data, believe it or not. They're fitness apps, they're diet apps, things like that, because there's been no straightforward way, if you're the proverbial kid in the garage, or frankly, even Apple or Google, you haven't had a chance to really, get into the healthcare bespoke interoperability. You want sort of a broader set of tools you can use. And so we're already seeing some of that. So for example, Apple's HealthKit, several thousand clinical sites now you can get on your Apple iPhone. There's a project to do the same thing in the Android space. I believe it's called Common Health, that is out there to get your medical record on your phone, when you can then transmit it using the FIRE resources. All, I believe, each of the major cloud vendors either has or currently has, which I know is the case for Microsoft, that they currently have FIRE servers on the Microsoft Azure cloud structure. So if you're a developer who wants to do cutting edge oncology, for example, right, merging in data streams, research streams, you can use the Azure platform with their Fire server. So that's one of the tools. It is my understanding that Google and Amazon are well along in building Fire servers, right? So this is that infrastructure, that plumbing, Cliff, that you ask about. This is what makes this practical and makes it practical at the scale of oncology. I mean, oncology is vast in scale, right? You have vast needs from imaging, you have vast needs from records, you have vast needs from genomics. So the tools have to be able to scale.
Got it. That's very helpful. Another question that's come is the following. This has to do with the major electronic health record vendors.
Mm-hmm.
And we know the two of them in particular, of course, and there are others as well. A couple of them take up a large part of the large market shares. What can you say about your understanding regarding how the large EHR vendors are supporting interoperability and using some of these tools that in a way that is responsive to clinician and patient needs? A lot of the practices we're talking about here depend on those vendors for their EHR systems, and how well are they working and playing well with others, shall I say?
Yeah, I think we've seen, frankly, since the Cures Act became law, a lot of progress there. I mean, you can argue about chicken and egg and incentives and motivations and things, but I would say the vendors are really, the major vendors have, I believe, all already built Fire APIs that they're rolling out. So they've all built them. They're, some of them are various stages of testing, but I believe all of the major vendors, we did a mapping about a year and a half ago. And so about 80+% of the doctor population, and I'm guessing probably close to 95+% of the NCCN doctor population, those vendors, just looking at the list of members and pretty much knowing the vendors, your vendor has built Fire APIs. Now, often some of the APIs are, there's still proprietary components there, but I think we're making some very good progress there. A number of them have built out, early test versions of the bulk population data APIs as well. The payers are very interested in this. From a clinician point of view, this is the kind of stuff that will, I believe, ultimately eliminate most of the prior auth games, the quality measure games, right? Because all of those games are because payers have no real way of figuring out what they're getting, what the value is, what the performance is. We're not used to it as docs, but from a computer science point of view, those performance tools are coming very rapidly. Pretty much any machine learning algorithm, if your goal is to separate, let's say, providers into quartiles, quintiles, deciles of care, which is certainly probably more refined than the granularity of today's quality measures, any machine learning algorithm can do those separations more reliably against big data than quality measures. And then a lot of the pain, which I think oncologists feel with high price medications on prior auth, will go away. The calculation of value in oncology medicines is going to be a very, very different game than what is being done today with this. These analytic tools and this speed of computing, it just changes marketplaces. And it's going to happen in healthcare, and it's going to happen in oncology. It'll be pretty rapid. It'll, all of a sudden it'll be there, but I assure folks, the underpinnings are there right now, this very second.
So Don, you bring up a fascinating and really sort of sometimes touchy, acute point with regard to value. I think I heard you suggest that the many data sources, greater interoperability, these analytical tools and platforms will help us derive or better understand value in cancer care.
Yeah.
I'd like to contrast that with a lot of the kind of discussion controversy now where value in oncology, particularly in advanced therapies, comes in the form of a calculation of cost per quality adjusted life year afforded by some potentially breakthrough therapy. We're talking about two different things. How would this value proposition or determination arise in the world that you are envisioning?
Well, when you look at the calculation of quality adjusted life years, right? Again, it was, when it came out, a big advance. I mean, I've been around long enough to remember before quality adjusted life years. So it was certainly a major advance in thinking. But again, it is, I think there are a couple components to it. So first of all, it is very much a measure that ultimately that was designed to incorporate patient preferences. It ultimately doesn't really incorporate patients' preferences as measured by their wallet, right? And what they choose to purchase. It measures preferences as elicited by abstract tools. That's, where they really don't effectively have an economic choice. So I think a lot of the things that we've talked about today are going to have economic empowerment, which I no disrespect to the researchers who've worked on qualities, that in the way that we've used it is not really there. They can certainly inform the conversation. But even skipping that, I think qualities are, they're a very bespoke calculation, right? You can't just go to a therapy or anything and sort of automatically generate these things, right? People have to sit there, people have to do work to do this. I think with modern data things, the information is generated automatically. Now, I'm not saying it's trivial, right? The fact that a machine learning algorithm can predict is very different than a machine learning algorithm being able to explain, right? So that's as people sort through the buzz of AI and things, ask yourself, it's one thing to predict X, Y, Z, and we've known this since, our statistics classes, correlation and causation are not the same thing.
But you're suggesting, Don, that the way that you're envisioning the compilation and analysis and synthesis of data can tell us even more about value in cancer care than we might have determined from, let's say, a quality calculation. That's what I think you're saying.
Exactly. I mean, it is multidimensional statistics, right? So we sort of know, remember from grade school, the X variable and the Y variable type of thing. And then, folks have done linear regression, logistic regression. I'm guessing for most of the audience, those are tools that folks have some level of familiarity with. This is really going beyond that into, higher dimensional spaces that, of course, mathematically, not in a Star Wars kind of sense, right? But it does make the explanation difficult, but it means there's just a richness of information. And when we combine this with a population level data, we really can think of science in a very different way than we've had to historically with tightly controlled trials, right? I mean, the classic oncology trial, a tightly controlled trial that has been the norm in academic medicine is really because we didn't have all data. So we had to have these very tight controls between the study population and the control population. In a world where you have all data, you don't actually need to do that. The fundamental reason to do that vanishes, right? You can't have more information than all.
Okay.
Right? And simply put, you just can't have more than that. And we're asymptotically getting to that when you start looking at these larger populations. I realize it's not all. And of course, that also then gets at some interesting things that have been very topical, such as equity and, racial differences and things. because if you have all of that information, you're really in a much better position to tease out what the various features are, what the populations are, how you can improve care for everyone. But those things really ultimately, I believe, are going to come from relatively less structured data than more structured data. And there's absolutely nothing that says that you can't use both.
So, in a sense, if we get that much data, as you point out, all the data,
Yep.
we kind of minimize biases, data collection biases and so forth that come from different sorts of observations.
Yes, as long as the people are, enrolled in the care, right? I mean,
right, they're going to get.
If folks aren't enrolled in care, then of course the biases, you have that fundamental bias, but, obviously we need to make care more affordable. I think that goes without saying, skipping, whatever your political preference is on how to go about doing that. But I think, I believe most, people are getting cancer care. I've spent most of my career in inner city emergency departments and taking care of disproportionately underserved populations. So I spent a number of years at Beth Israel in Boston, at Presbyterian, Penn Presbyterian in West Philadelphia. Ohio's not quite as much inner city, but certainly at Ohio State. So I'm fairly familiar with, the needs of folks who are underserved and have had the privilege of taking care of those folks. So I think this will be very powerful for them. And the biggest power actually comes from being intelligent about resource allocation, right? Because that's been, I think, the rub on oncology of expensive meds and, what things work, what doesn't. So these data streams, I think, are going to provide a clarity here that has been missing.
Good. And time for it to have it too. We could use it.
Yeah.
Quick question I'm going to toss in there. And I'm going to read it almost verbatim. And that is, you made a reference earlier to the more seamless and more complete data and information available in the arena of sports. Wouldn't that be cool? But in an attempt to maybe mirror that in health-related information, we may be hampered by the need to de-identify and protect variable elements. So aren't those protective elements and de-identification and so forth, don't those mitigate against a seamless information system? And can you answer that in like 90 seconds or less? De-identification is important. It's technically extraordinarily challenging because how you re-identify data there are many ways to do it. I would throw out, just to leave on a science high note, there's something called split learning. There are a number of folks who have been involved in this. So Ramesh Raskar, for example, at MIT. And the concept there, just to give people a sense of how technology may help here, is you have these multi-layered neural networks. And the data that is identifiable is abstracted out at the site into a middle layer of the neural network, at which point it's totally de-identified. And then, but that data doesn't leave the site, and it's only the middle layer of neural network calculations that leaves the site for the broader roll-up. So there's some fascinating technologies to think about de-identification that can harness what we just talked about while protecting increasingly re-identifiable information. Got it. Don, in less than a minute, you've been there for a while. It's got an important role. Your office has a very important role. In less than a minute, your single greatest challenge. What's the challenge that you in your job, your role that you face, you say, gosh, I got to get over this one? What might that be briefly?
I think it's just, we just need to move the application programming interfaces, get them everywhere, get them hooked up with the health information exchanges. We've done a lot, but there's a lot that needs to be done there. And ultimately, these are political, economic discussions way more than they are computer science discussions. Not that the computer science isn't extraordinarily important. So it's the role that ONC has had, all the prior commissioners, myself, commissioners in the future, hopefully the coordinators, in getting, moving that along. What we've done, it's literally coordination of care.
Got it. Well, Don Rucker, I must say that usually when I'm engaged in conversations with people in your field, my comprehension's probably less than 5%. And I got to say that the way you've laid things out really brings a lot of clarity to this. A guy that can explain FHIR and TEFCA the way you have, and some of these other aspects of interoperability and kind of where you're trying to take this function has really been much more clear and comprehensible than a lot of folks have done. And I must say I've learned a lot. And I also we very much appreciate how you've talked about these advances insofar as having an impact on clinical care in oncology. So much appreciation for your effort and your ongoing work, Don. You're the right guy in the right spot, and thank you very much.
Thank you, Cliff. Thank you, NCCN. Take care, everyone.
All righty, thanks, Don.